Hang on a second.
Did I?
I'm not sure. Okay, how are we doing?
I'm good. Letting everyone in right now. More. It looks like everyone is in. We have 21 participants. Okay, everyone is in. We will be beginning the webinar momentarily. Thank you for your patience.
Yeah. Good.
All right. Thank you everyone for joining us today. We are Greenberg Regenerative Medicine, and we are going to be talking about everything you need to know about regenerative medicine today.
Regenerative medicine.
I'm excited to introduce to you Dr. Scott Greenberg, who is a world-renowned integrative and regenerative medicine physician. He's a member of Bryn Mawr Hospital, an affiliate of the Mainline Health DM Center for Integrative and Regenerative Medicine. Additionally, he's a clinical professor at the Marcus Institute for Integrative Medicine at the Thomas Jefferson University Hospital. Dr. Greenberg has treated patients, including pro and Olympic athletes from all over the globe. Issues, regenerative orthopedic problems, chronic pain, arthritis, and post-concussion syndrome. He uses state-of-the-art therapies such as prolotherapy, PRP or platelet-rich plasma therapy, and he's a pioneering leader in developing and using stem cell-based procedures. His restorative programs are holistic, non-toxic, and opioid-free. Dr. Greenberg identifies and fixes the root cause of his patients' problems and helps them harness the power of their body to heal themselves. I will now turn it over to Dr. Greenberg to begin the webinar. I'm excited to introduce to you.
Hi, everyone, and thank you so much for joining. This is going to be a webinar where we talk a lot about orthopedic regenerative medicine. My name is Dr. Scott Greenberg, and I practice at the Bryn Mawr Hospital, as Sharon, my office manager and assistant, said. So let's get started. So anyhow, any medical conference that I've ever been to always starts with a joke, and why not do the same thing here? So anyway, pain is a very prevalent in which I deal with every day. And, in this little cartoon here, the woman's saying the pain starts in her husband's lower back, then it travels up his spine to his neck, then comes out his mouth and into my ears. And that's why I get these headaches. So I think this is really cute. And also it's really a great way to illustrate that when you're really trying to take care of patients with pain, we really want to look into what's the underlying cause. So in this case, the woman's underlying cause for her headaches is not her head, but it's really her husband. So we want to treat the cause, not any of the symptoms. So I just want to give you an example of we deal with a lot of patients that have issues and problems that have either exhausted traditional modalities, or there really are no great traditional options for these patients, as you'll see in this video, in this woman who unfortunately has significant compression in her spine that it's damaging the nerves and is causing issues with her hands and feet. So we can play this video and you can see.
I was unable for years to turn my head. I was looking behind me. I was looking in the rear mirror, and I
my AirPods.
I just couldn't do it. It was really bad pain.
It's a terrible thing.
My neck I have problems with like clicking and just pain. I couldn't sit in a theater and look to the left without putting myself in the, but after the stem cells and the PRP, the feeling in my feet, it's like this months later now, I feel the left is like almost completely normal. And the right is like back to cotton. It doesn't even feel, or maybe like that you had a Band-Aid, but it doesn't really have the, it's not negative, and I can walk. I have no problem. I was walking before too, but it not without awareness of that feeling. And that's improved greatly from the beginning on till now. And presumably it's going to get even better. We'll see.
So this woman illustrates some interesting points. I mean, first of all, when you have damage in the spine that affects the sensation in your feet, there really aren't any good treatments for it. In addition to that, there's a lot of what we call comorbidities, which means things that happen from having an illness that are prevented by us repairing the damage in her nerve. For example, if she continued walking like this to where she had no sensation in her feet and was off balance, she could fall and break a hip. And that's, as you probably know, a really devastating thing. The other thing that this woman also had as well is she was really losing strength in her hands and was dropping objects and couldn't button her coat easily or couldn't open a jar. And, when you can't function, it really impacts your quality of life. And the reason why this happened was because she had significant damage in the nerves in her neck and degenerative arthritis there that was impacting how the hands work. So therefore, we were able to restore, not only the anatomy, but also fix the nerve function. And she has a really important and significant improvement in the quality of her life. So how did I get started doing this? Because I've been doing this for over 22 years now. And, people may have heard of stem cells more recently, but I've been involved in this field for a really long time. And it has a little bit to do with Dr. Coop, who was eventually my patient. I took care of his spinal problems. But before I did, in the 1960s, he actually had treatment for his back when nothing else was helping. And he flew out to Chicago, and a Dr. Hemwall had evaluated him and treated him and helped his condition. So be that as it may, when I was a kid, I wanted to be a retinal surgeon. And I wanted to do so because my grandmother had a condition known as macular degeneration, to where she was legally blind. So my only reason to be a doctor was to help blind people. Unfortunately, when I was 18 years old, I was hit by a drunk driver at about 75 miles an hour and had really suffered in chronic pain for about 10 years, which we'll talk about. So I didn't know about post-concussion syndrome, and neither did the myriad of doctors who I had seen for years, whether it was after my accident or in college or in medical school, who had tried to help me. And when I went to do my ophthalmology rotation, I couldn't see through the ophthalmoscope to look in people's retinas. So therefore, the ophthalmologist that I was working with said, "Oh, you can't be a retinal surgeon." And I asked him why. I said, "How come I can't see into people's retinas?" And he really didn't have an answer for me, because nothing was really known back then about what I know today in regards to the interaction between the cervical spine and what happens in accidents and the eyes. So two good things. Number one, I can see in people's eyes now since I was able to fix myself. And the other interesting thing is that the ophthalmologist who I was working with back then, he's my patient. I take care of his joints and he takes care of my eyes. So it's funny how life goes full 360. Be that as it may, when I was 28 years old, I was still suffering horrifically in pain. I'd wake up at least several nights a week at 3 o'clock in the morning, feeling like someone was drilling through my skull. And it was just such an awful feeling. So I had heard that Dr. Coop had had this treatment in the 1960s, as I mentioned, and I went to learn from a doctor who learned from the doctors who treated him and kind of got some of the basics down and things like that. And unfortunately, one night again, I was suffering in horrific pain. And I started examining myself in the middle of the night, and I could feel how parts of my spine and base of my skull were tender on the same side that correlated where my headaches always were. but my other side was perfectly normal. And I thought to myself, well, what would happen if I treated myself to see if the problems in the back of my neck and in the base of my skull were actually causing the headaches in the front of my head, which back then really was a novel thought, and no one had really known anything about this. So I drove in the middle of the night, started concocting some solutions, and fortunately had the skill and I guess you could say the guts also to treat myself in my upper cervical spine, the base of my skull. And I was very fortunate enough that in the next 4 months of treatment on myself, I was actually able to cure my 10 years of suffering. And again, this is 22 years ago. So this is how I started getting into this field, was treatment of myself. So here's my team, because I can't do it alone. I have a great team, including nurses and administrators and another doctor who helps me out. And they're a wonderful team, and they really just make my life great. We get along like family, and that's one thing that we really believe in, teaching our patients and treating them like family. It does take a team, and we have a great team here, and I'm proud to call them people who I work with. So, as I said, I deal with a lot of people that have problems with pain, and unfortunately, the traditional options have not helped them, and that's why they're coming to me. So, if we look through the different traditional options for pain, yes, we can all take medications such as anti-inflammatories and Tylenol, and some people are given muscle relaxants. Sometimes people are given nerve blocks and steroids, and sometimes nerves are burnt of damaged areas. Then there's other therapies that are surgical, such as back fusion and laminectomies. And I do see a lot of patients who have already undergone suffering. And then with other joints as well, there's meniscus surgery for the knee, there's rotator cuff repairs. And, when we look at these types of options, they seem to sound very good, but when we look at the data behind it, they're not very good. And for example, with meniscus repair, if it's done on patients who have arthritis in their knee, which a lot of my patients do, and you start to take out part of their meniscus, it actually leads to having knee replacement much sooner in life than if you never had this meniscus repair and just let things be. So unfortunately, here in this case, the surgery is quite harmful. And the number of meniscus operations on older individuals has decreased somewhat because of this data, but it still leaves people to suffer in pain if they don't want to get a knee replacement, which is their only other option. In addition to that, sometimes regenerative options are better than traditional options, to where if someone has a significant rotator cuff tear and they get it surgically repaired, the re-tear rate is actually up to 5 times higher than using regenerative treatments. So the regenerative treatments we're going to talk about include prolotherapy, PRP, also known as platelet-rich plasma, and stem cells. And again, most of my patients have undergone and exhausted all of these options for pain, including the quote alternative therapies, end quote, such as massage and homeopathics, and taking chiropractic manipulation and acupuncture and all these things. So, for me, it is always a challenge and very interesting to deal with my patient population who either doesn't want surgery or who has had surgery, and they still have problems that need to be taken care of. And fortunately, we can usually help them, which makes it very enjoyable to fix them. So again, we're going to talk about regenerative orthopedic medicine is our topic today. And there's many different tools that we use in regenerative orthopedics. So one of the first things that was discovered was something called prolotherapy. And believe it or not, the primitive form dates back to the time of Hippocrates. And it's been passed down to us that Hippocrates was the team doctor for the Olympics, just like I've dealt with a lot of Olympic athletes. I guess he did also. And the javelin throwers would historically have problems dislocating their shoulder after time if their shoulder would wear out. And Hippocrates thought to take some type of hot poker, which obviously we don't do nowadays, and to put it into the javelin thrower's shoulder in order to help increase the tissue density. And this would stop the dislocation of the shoulder. Now, back then, he was causing scar tissue, and with the modern agents that we use nowadays, we don't do anything like that. We cause regeneration, not scarring. So the things that we use could be as simple as a lidocaine and dextrose solution, but there are other things that are used for regeneration. So a more advanced form of healing with regeneration is PRP, or platelet-rich plasma. And you may have heard of this because athletes, such as, unfortunately, he passed, but Kobe Bryant used to get PRP injections into his knee to help him play basketball, and many other pro athletes who you may know or not know about have had PRP injections. And PRP contains many different growth factors that the body uses to heal. And we essentially extract these growth factors and inject them into the damaged area and make the body heal, which really is ideal because that's how the body wants to act naturally. And that's why I think this is such a successful type of treatment. So a more advanced treatment is using stem cells. And originally, there was a lot of research that was done on bone marrow stem cells. And more recently, I'd say in the past 10 years, a lot of the research has switched to using adipose or fat-derived stem cells, which is something that I really favor far over bone marrow. But bone marrow has stem cells in it. The stem cells could either go to form blood or to form tissue. And while stem cells are manufactured in the bone marrow, the majority of the stem cells are stored in the fat. So that's why I really prefer fat-derived stem cells, because I think it's better to go to the warehouse where the stem cells are stored in highest concentration compared to where they're made. And the other interesting thing about the fat is the fat contains a lot of other really interesting growth factors that help with formation of cartilage and also help with formation of nerve tissue. For example, when we have patients who have spinal issues and have nerve damage, or for the arthritic patient that has a significant loss of cartilage, whether it's in their shoulder, in their hip, or in their knee, the stem cells can be very, very helpful in getting some of that cartilage to grow back. So there are also some other biological things that are used, such as amniotic membranes, which contain a lot of growth factors, and then some other products that are derived from the placenta as well. And we really don't use them because even though they may be beneficial, there's really a big question around the regulation of them. And there have been some infections linked to them, so we don't believe it's the safest thing to do. And we have very good outcomes with how we prepare our tissues. So we like to stick within the letter of the law and not use those products. So how does this happen? So again, as I mentioned before, this all happens through a matter of different cell signals. And I don't want to confuse you with the different biology here of all these different fancy names, but as we go through, and if we look at the next slide also of what we're talking about here, these different cell products basically do something that's pretty ideal. They mimic the way that the body works to heal tissue. And if you look at the different things that are written next to these different products, such as IL-1RA, which is the top growth factor here, it helps to counteract cartilage degradation, and it basically reduces inflammation. So to me, that's really a novel thing to use, and why not use it and help people with that? It's funny because I was actually having brunch with my brother-in-law today, and we were talking about some of the ideas that I have in regenerative medicine. And he's like, well, why don't you just take one growth factor and manufacture that and use that? And I was telling him that the body really acts in concert, and all these different growth factors that you see work together in order to produce an end result. So this is how the body works. So I like to mimic how the body is repairing tissue and reducing inflammation and helping arthritis, rather than trying to extract out one or two chemicals, which may be a small part of the repair process, but not the whole picture. So when we use what the body has, I believe that that's the best way to go, to mimic the body. And again, to sum it up, these different growth factors reduce inflammation, reduce the arthritic expression, and also help to promote regeneration. So how do I go about this? And like any other doctor, I believe the most important thing is to take a good history and a physical examination. A history obviously will tell you how long the person's problem has been going on for and what they're related to, because that can give you a lot of clues as to what they're suffering with. And then I think it's really important to examine a patient and examine them very thoroughly. And this is something that, in my opinion, is really being missed in modern medicine today, that we rely so much on MRIs and ultrasounds and x-rays. Now, while I look at all of those in evaluation of my patients, I don't think that we should really decide what we're going to do based solely upon an MRI. I think we really need to examine a patient very carefully to know what's going on. So when I write here that we do a dynamic observation, it's really important just to do things like watch a person walk. And you can learn a lot from that alone. I had a patient in recently that unfortunately had 2 stem cell procedures done at a different location, and rather than our office, and he wasn't really getting any better, and he already had a surgery on his knee. And when I looked at him, I saw a few things. Number one, his pelvis was tilted with abnormal pressure on the knee. His arch of his foot was caving in. And you ask yourself, what does this have to do with anything? So if your arch of your foot caves in, then your shin torques inward and it's constantly tweaking his knee. In addition to that, there was a ligament that I found that was damaged in his knee that was not seen on MRI. And with all these things not being treated, no wonder he's had these different treatments done and nothing has helped him so far. And he's still suffering, even though he's only 33 years old. So we really need to look at all these different things in addition to our traditional tests in order to make the best outcome for our patients. So this is what I call the Greenberg method. And we can go to the next slide. So in the Greenberg method, I think we always have to look at biomechanics. It's not like just looking at someone laying on a table. We need to see how they stand. And if you look here in this person on the left, you see that their knee is rotated in by a pelvic tilt. And this could be a perfect case to where someone's arch could collapse. And then if you note, if your spine sits on top of your pelvis, you have a lot of torque going up your spine, which could contribute to things that seem very common sense, like scoliosis. This can certainly be a big contributor to scoliosis, but also can damage the joints around the lower lumbar spine, can cause a lot of sacroiliac and piriformis, kind of the things that we don't think about when we're evaluating someone with pain that I think we really need to evaluate. And because taking care of these issues can be really, really important, as I will show you in a video later. So we'll talk about the knee, and if we get started, there's a lot of different things that we need to look at. And again, you might see an X-ray and you're going to see a few bones, including the kneecap and the tibia and the fibula and the femur, but you're really missing a lot of the structures, such as the medial collateral ligament on the inside of the knee, and acts like a knee brace. This is your body's natural knee brace, and it's almost all the time where I see patients who have damage to the structure, and it's not usually diagnosed and not ever treated. And without it, people can't do simple things like go up and down the stairs comfortably. So one thing that we need to restore in virtually all of our patients who have knee problems is the MCL. So again, we have to kind of think outside the box in order to give the best outcomes to our patient. And as I said before, not only look at the knee, but also look at the foot. What is the foot doing? If the foot's rolling in, it's providing torque to the knee. If the pelvic tilts and their pelvis is rotated, they're not going to walk properly and they're going to put abnormal pressure across their joints. So these are the things that we do in what I call the Greenberg method. So there's a lot of different causes of arthritis, such as rheumatoid arthritis. There's Lyme disease cause arthritis, but most people have a degenerative type of arthritis, which is due to wear and tear. And then also when you start this wear and tear, the immune system just kicks up, and then one bad thing leads to another. So in the treatments that we offer, including prolotherapy, PRP, and stem cell procedures, we try to reverse that damage. So if you look to the left, we have a nice healthy knee joint, and then to the right, we see an arthritic knee joint. And the arthritic knee joint, not only, as I said, happens from wear and tear, but also it changes in the biology of the inside of the knee that cause the cartilage to degrade, the bones to become erosive, and the whole joint wears out. Now, we used to think that this was just a wear and tear condition, but it's not. I see patients in my office that not only have premature wear in their joints and have not done that much from a physical standpoint, they weren't pro athletes, but they have premature wear. And also they may have a lot of family members who have arthritis. And that's because the biochemistry of what's going on inside the joint is helping to accelerate the arthritic process. So we not only want to fix the structure, but we also really want to try to help the biology of the joint as much as possible. So PRP is kind of like the Pac-Man of arthritis here. And, there's a lot that goes into PRP that helps not only to repair the joint, but also remove a lot of the debris and help to modulate some of the abnormal biochemistry that goes on in the joint. So it's not just a one-trick pony. There's many different ways that this works to help people. So in a PRP procedure, what we do is we take out people's blood, which sounds a little scary, but I can tell you that I have the best nurses in the world to take out patients' blood. It's a very painless procedure. And we're not taking out large quantities, but large enough in order to do what we need. And then we put it through a process in our laboratory where we basically extract out the platelets and growth factors, and then we inject the PRP into the damaged areas. And again, with the way that I try to treat all of the damaged areas, not just put one shot into a joint and hope that that works, because I do not believe that works. And, unfortunately, I've seen a lot of people who have had treatment like that with PRP, and they don't really get the results that they need. So I was part of the team that helped to show the first evidence that stem cells can actually rebuild cartilage tissue in the knee. And this is a really cool study that we did. We took a person who was 57 years old, was having a lot of problems with his knees. He already had surgery years ago, and he couldn't do the things that he wanted to do, such as ski. And this is really, really aggravating to him. And as I'll show you in the next coming slides, his knee was scoped, and the scope showed a big tear in the meniscus. So as I mentioned before, if you operate on the meniscus and you trim it, it will actually accelerate arthritis and lead to a knee replacement sooner than if you did nothing at all. So with this patient, we decided to do a stem cell procedure followed by PRP. And if we go to the next slide, here you can see the meniscus tear when we scoped him. And then 9 months later, the patient agreed to have a scope again with his knee. And we saw that the meniscus tear was completely healed. If you look where the probe is, there's no longer any tearing of the meniscus. The nice thing is, the next season, this patient was on the slopes and skiing very hard and doing all the different types of exercise and everything else and loving life. So we not only cured the patient with his symptoms, but also showed that with directly looking at the tears in the tissue, they had healed. So this, to me, is what regenerative medicine is all about. So the results were that we pulled out the cells, we analyzed them in the laboratory, and showed that this is really a very safe and effective way to help someone's knee without surgery. And again, the arthroscopy point we just did to prove our concept of what we were doing, to actually look directly inside the knee and show the healing. But it's not something that we do on a day-to-day basis with our normal patients. We know that the procedure works, so we treat them and help them heal and get better. So also, as I mentioned, bone marrow was used before in a lot of stem cell procedures, but with this, we really showed that adipose can do things that bone marrow can't do, and they've never shown a case to where bone marrow can heal a meniscal lesion like we showed in this tissue. So this is a really important effect, not only for the patient, but also for science. And there are many different studies that have come out since I published this material showing how the fat-derived stem cell tissue is really significant in helping people with arthritic pain. And here's just a few publications that are in PubMed. And we're really excited about this work. And I work also with a biotechnology firm in regards to helping to further develop tools that help to process fat in order to help people with arthritis. So I think it's really, really an important thing. So there are other options that people can pursue, whether they're cortisone injections or what's known as the gel shot, which the gel shot is hyaline cartilage that's ground up and synthesized either from rooster combs or made synthetically in the lab. And the common names of these are like Synvisc or Orthovisc. You might have heard these brand names before. And PRP was compared to these other types of injectable agents, and PRP was far superior to these types of gel shots for people's knees who suffer with arthritis. So back pain is one of the most common things that I see in my office. We deal with it every single day, and most people in their life will experience back pain. And there are many, many, many different causes of back pain, whether it's scoliosis or spondylosis, which is like a degenerative arthritis of the spine, or spondylolisthesis, where the spine is slipping, or you kind of put all these things together along with disc bulging and arthritis, and you get something called spinal stenosis. So there's many, many different diagnoses that we deal with patients that have back pain, but it's very, very common. And the traditional treatments for people are the usual physical therapy and epidurals, or sometimes doing what's known as a rhizotomy, which is burning the nerve, or putting people on pain medicine like gabapentin. But a lot of times these things don't work. And what's the person to do after they've had 3 epidurals and they don't want to have surgery, or the surgeon says the surgery won't work for them? Then the patients, will end up eventually making their way to me. And fortunately, we can help them with our evaluation and treatment. And as I mentioned, I use what I call the Greenberg method, which is not only looking at the patient's back, but looking at the pelvic tilt and looking at rotation and looking at how the person walks. And even though I'm a board certified MD, I still do use some gentle manipulation techniques that have been taught to me by chiropractors and osteopaths over the years, because I think we really need to try to get things in position as well and use the best of our medical knowledge in order to help our patients with whatever tools that we have. So that's why I use the Greenberg method. And again, we'll get back to this with the tilted pelvis. So again, if your pelvis is tilted, which I see all the time in patients, I don't think I've ever seen a patient in 22 years who has had back pain who has not had a tilted pelvis. And the torque that it produces across your back is tremendous. In addition to that, as I said before, your spine sits on top of your pelvis. And if it's tilted, the damage in the joints that occurs just from this is really significant. And people generally don't know and don't realize that their pelvis is tilted. Sometimes a loved one may say to them, oh, you're limping, or you're not walking properly, or stand up straight. And they may notice that, but I notice it all the time in people, and they're often undiagnosed with this problem. And fortunately, it is relatively easy to correct, and it makes a big difference in patients' life. And when I correct it, I have people that generally limp into the office and they walk out much smoother. And sometimes this can produce really immediate and significant reductions in a patient's pain, and also help their walking distance immediately. And that can be for someone that has an arthritic hip, an arthritic knee, or spinal stenosis. So it really affects a lot of different areas from one problem. So here I'm going to show you a video with a patient who has back problems and an arthritic hip. And her arthritic hip is very severe. So you'll see the difference in how she walks before and after the treatment of the pelvic tilt. Having a lot of back pain, hip pain, and knee pain. And when I put my hands on her pelvis, you can see that this side is really low and this side is really high. And I can't push her this way very easily, but I can easily just tap her and knock her right over like that. So, and that was with minimal pressure. You'll see how difficult it is for her to walk. You see the patient's wobbling here, and her gait's really difficult. So we're going to treat this dysfunctional neuromuscular pathway, which causes the pelvic tilt. We're going to correct it and see what happens. So we performed the treatment and corrected the abnormal pelvic tilt through injection. And now you can see when I put my hands on her pelvis, they're perfectly level, as they should be. And when I push her over, she really doesn't go, where before I just could knock her over more easily. Now let's watch her walk and we'll see the difference from correcting the pelvis. You can see here the patient can walk much faster and also much smoother. And the patient says that she's feeling better already in regards to the pain that she had. So these types of treatments are not only about treating the joint, but also fixing what's wrong with biomechanics. And that's what the pelvic tilt treatment is all about. So this is one of the integral things that I use on my patients all the time is treatment of pelvic tilt, and it's so significant in giving patients results. And as you can see with that patient, it made a very significant difference, not only in her pain, which I'm reporting back to you, but also her walking, her speed increased significantly, and her limping went down dramatically in a matter of minutes. So, which is good. So with back pain, we need to think about things because everyone knows about disc problems and people get treated with disc problems, but there's a lot that goes into the back, and all the things that you see here on the slide actually support the back. And if you lose the support in any one of these structures here, you'll also have damage to the disc. So it's really important to look at all of these structures, not only if there's a disc problem, but if there's not a disc problem. Because things like if you see on the left here, the piriformis muscle and tendon, that goes right over the sciatic nerve. If there's damage in that region and the muscle tightens, then it's going to hit the nerve and give you sciatica, but it's not coming from the disc. So we really need to look at everything in the lower back that can cause problems and treat all these problems. And the way I like to have people understand this is that this is like the Eiffel Tower, the back, and the areas in the bottom support the areas in the top, kind of like the Eiffel Tower. And if the Eiffel Tower gets loose and weak, everything starts to collapse. And as it collapses, we get pain, we get disc bulging, and we get dysfunction. And what we do kind of restores the Eiffel Tower and makes it a normal structure again. So if we look at another view here, here's all the different ligamentous fibers that come from the hip and the sit bones and go all the way up and insert into the spine. So when I evaluate people, I need to look at all of these different areas and possibly treat these different areas in order to get people better. And again, I'm dealing with patients that are at the end of the ropes, at the end of the line, and many of them have very common causes for pain that can be treated. And this is what we do. So here's a really interesting case history. And here's a patient in his MRI. And as I said, I'm a traditionally trained MD, and this is why we look at MRIs. And two things that I notice here is number one, the herniated disc, and then also there's a lot of degeneration in the spine, and the spine is very straight from muscle spasm. So if we go on these slides, we'll see that here's the disc bulge, and then I treated this patient with PRP. And interestingly enough, I did not inject into the disc. I treated the Eiffel Tower, as I call it, and reinforced and rebuilt all of the tissue around the disc and also around the sacrum and pelvis, which are common reasons for people to have pain. So not only did this patient improve and his symptoms all went away and he went back to motorcycle racing, which he loves, but if we look at the next slide, we will see that the herniated disc resolved. And again, it resolved without me even touching the disc because I rebuilt the connective tissue structure that holds everything in the spine. And, this is really a neat thing to show people, because everyone thinks that if you have a damaged disc that you need to go in and have it operated on, or that that's always the cause of pain. And often it's not. But if we just treated disc, because there are doctors now that do treat discs with PRP, again, I think we end up with very limited benefit. And that's more or less treating the symptoms rather than treating the cause. And I truly believe in treating the cause of the person, and just treating the disc does not end up producing enough benefit, in my medical opinion. So if you look here at this slide, here's just, again, research that talks about the kind of things that we do. And in this study, about 90% of patients with chronic back pain experienced significant and long-term relief. And I bring up the term long-term because, again, this is regenerative medicine, meaning that we restore, we rebuild, we reconstruct. So reconstructing and rebuilding things produces long-term results. It doesn't produce short-term results, because we're not just injecting something to kill pain or to treat pain. We're actually doing something to fix the body so that the pain stops naturally on its own. So that's why, for me, I've been great for 22 years in regards to my pain problems, because I rebuilt the damage that happened to me from my accident when I was 18, and it just didn't linger. It went away because it was healed. So if you look at all these different research studies, there's many different conditions here. And again, regenerative medicine works. And there's good evidence behind the things that we do. And these different modalities really have a lot of science behind them, even though it may not be considered mainstream at this point. But we're changing that little by little, day by day. So again, here's another study with sacroiliac problems, which is one of the reasons why people that have chronic back pain. And again, we had a very significant improvement in patients' pain. And guess what? When they looked at their pain 4 years later, these patients were still doing much better than those that did not have the treatment. So again, long-term relief for patients is what we're trying to achieve. And it's really great. As I mentioned before, part of my team who I have is another doctor who helps me out. He was a patient of mine 21 years ago, and he was supposed to have spinal fusion in his 50s, and now he's in his 70s, and he has not had spinal fusion at all. And prior to treatment, 21 years ago, he was only able to stand for about 5 minutes at a time before he had to sit down because of his spinal stenosis. And now he can work all day long. So these are the kind of results that we look for. And again, if we look at steroid shots, if they work, they generally wear out very quickly. So the rate of steroid shots working is far less than with PRP working. For example, a cortisone shot or an epidural may only work in 20 to 30% of patients. And again, with PRP, we have results that are greater than 90% if it's done properly. And the PRP is going to last and last and last, to where the steroid shots, if they do work, you need to have them done often every 3 to 4 months. And sometimes patients may get a year relief out of them, but it's never healing any of the damage. It becomes a long-term type of thing for a patient who's suffering chronic pain. Yes, I do use steroid shots sometimes in acute problems, or someone may have a frozen shoulder. So there are reasons why people can get them. And I'm not saying they're always bad, but I think that there's better options for patients. And they really need to be used judiciously, because if you inject steroids in enough time into a person's joint, you can actually accelerate the arthritis. For example, in a knee, this is why they'll only give you 3 shots a year, because doing more than that can be very harmful to the joint. So again, using stem cell therapy, which we do in patients who have spinal problems, has been shown in studies to be better than epidurals, safer than epidurals, and lasting longer than epidurals. So to me, this is really an ideal treatment. And that's why I specialize in this type of therapy for patients rather than the traditional medical approach, because I think there's just a much better way to help people with their back problems. So instead of getting an epidural that may or may not help, I think rebuilding someone's spinal problems for hopefully for a long, long time is the way to go. So again, I've talked a lot about stem cells. So what's this all about? So anyhow, as I mentioned, we really want to harness the body's biology. So the stem cells we take from the patient, because that's how the body heals, and that's how you heal, is by your stem cells. So we collect them from the patient, which I do so in a very simple process where I make 2 tiny incisions, only using local anesthesia, like a numbing agent, around someone's waist. And then I numb the area underneath their skin. And then we harvest out the fat, which is everyone's favorite part. They love to get rid of their fats. And then in our laboratory, we process it in a way in order to extract out the things that we need. And it's done within the FDA guidelines of processing human tissues. We're very, very careful in what we do as well, not to violate any type of federal rules. And then the stem cells are treated into the damaged area. And it's done so in a very safe and very effective way. So there are many, many different things that we deal with. And some of the things that I deal with, as I said, I kind of developed for myself, and all the post-concussion treatment that I used on a lot of the guys on the Flyers and other major athletes was developed because I had my problems. So again, take Life 360. So we see a lot of people that suffer from concussion and headaches, and also something called cervical cranial syndrome, which we'll talk about in a little bit. And this could happen from, hitting a ball too much in soccer. It could happen from having poor posture at the computer, or it can just happen from wear and tear over time. Or even we know if someone had a car accident, even if it was years ago, that people who have car accidents have significantly more pain and more headaches than those that have never had a car accident. Even years later, the results can happen. And it does not have to be an immediate effect of the accident. So again, we have the traditional methods of treating pain versus my method, which again produces long-term healing and a pain-free life, which is what we're looking for. So if we look at this, the reason why I bring this in, and I know this may be very tactical, is that it really isn't normal on the right. And give me 1 second to take a sip of water. The MRI on the left has a nice curve to the spine, but the one on the right has a very straight spine. And this is really important because if the spine straightens, which it does from damage to the neck, then it influences the brainstem. Excuse me. And the brainstem is the biggest nervous system control in our body for what's called the autonomic nervous system. And it really affects everything from heart rate to anxiety, to our eyes track, sometimes our balance, to even anxiety happens through the autonomic nervous system, and it's found in our brainstem. So while we think that problems like this may not be related to the brain or may not be related to the neck, they often are. And having a very good neck really leads to having a better autonomic nervous system function, which helps to take care of a lot of different neurological issues that you would never think. In addition to that, damage to the neck can also produce pain that radiates into the head. But you may not feel tenderness in the person's head, but you may feel tenderness in the person's neck or base of their skull that's causing their headaches. And again, this is why we need to look for the root cause of the problem and treat that problem in order to make it go away. So here's things that I see on an everyday basis. People who suffer from dizziness, headaches, difficulty with concentration and focus. They have blurred vision. They have ringing in their ears known as tinnitus. Sometimes they have heart racing, as I mentioned, or anxiety. And you would think, what does anxiety have to do with a neck problem? Well, it does. If your nervous system can't function properly, then you're in overdrive, and the nervous system that helps to calm you down doesn't work properly. So it's sort of the same thing with the tachycardia or rapid heart rate, that there's a balance in the body between the nerves that help to slow you down versus the nerves that help to speed you up. And if they become, your heart can race for no reason at all. So these are the things that we need to look at in regards to cervical cranial syndrome or damage at the base of the skull and in the cervical spine. One of the neatest things that I do with patients in order to help with the diagnosis, if you look here on the bottom right, is difficulty with tracking objects. And if I look at a patient and see they're having trouble following my finger or can't do a simple finger to nose task, we can often do some quick adjustments to the patient, to their cervical spine, and also to their shoulder blades. And if the shoulder blades are abnormal, then as I showed you before, the body is all connected. So the shoulder blades pulling on the cervical spine damages the nerves, and we can often fix that quickly and then take a person who can't track objects to all of a sudden within minutes they can track objects again. And it's really a neat thing to do with patients. And again, it helps to not only relieve their symptoms, but also show them a diagnosis that otherwise often goes overlooked. So again, we really want to treat the joints and not just the disc. And again, this happens in the neck as well, that treating the joint showed to be 90% effective for people who are suffering from disc herniation. So again, I'm just illustrating this point again. We really need to look at the structure of things and not just the MRI, because joint damage will often not show up in an MRI finding. And again, this is why I examine patients really quickly. Really carefully. So if we look at other uses for pain, there's many, many different things that we see. I did talk about rotator cuff issues just generally before with surgery, that the re-tear rate is very high. Believe it or not, if someone has a large rotator cuff tear and they undergo surgery, the re-tear rate can actually be as high as 90%. But with regenerative medicine, it can be under 10% according to the studies, because regenerative medicine helps to heal the tissue. And often with a rotator cuff tear, many times on MRI, we may only see one tendon torn, or maybe one tendon's torn and we see part of another tendon that has a little bit of damage. But when we're treating with regenerative medicine, we can look at all the tendons that are damaged and base something on examination and treat the four tendons that are rotator cuff, the different attachments between the shoulder and the shoulder blade, and look at the biceps and everything else. And we end up with a much better outcome than with surgical outcomes. And also the patient doesn't have to suffer for months and months and months after they've had a rotator cuff surgery. So they're kind of getting the best of both worlds, in my opinion. They're generally getting a better outcome than with surgery, and they're also getting less pain through the healing process, and the rehabilitation becomes much, much easier. So we do deal a lot with TMJ, rib problems, golfer's elbow, tennis elbow, any joints that you can think of. I've probably have injected many, many, many times in my career. One thing that I do see a lot of are patients that have hypermobility and something known as Ehlers-Danlos syndrome, which is a genetic problem to where people's are not built with the same strength in their connective tissue. And generally my patients with EDS end up having multiple problems from head to toe. And we usually have to fix most of their body. But again, we take people who are suffering from chronic disabilities with EDS, and we give them their life back again, which is, really a truly amazing thing. And for me, it's a blessing and gives me a lot of joy in my work to be able to help these people. These are people that sometimes they lift their arm and their shoulder slips out of place and their shoulder dislocates. But once we fix it with regenerative medicine, they don't have to worry about that anymore, because the tissue's healed, and it's healed stronger than it ever would have been through their native genetics. And they don't have to undergo, surgeries that can often leave a lot of scar tissue. We actually rebuild their natural normal tissue. And to me, this is far superior than having surgery for a joint that dislocates all the time. So anyhow, I think we talked about this before, and this again is just showing things in the rotator cuff. And again, PRP fared far better than having a steroid injection into the rotator cuff for rotator cuff tendonitis. Again, repairing the damage works better, and it's safer, and it helps for a much longer period of time. Often I do stem cell procedures when people have larger rotator cuff tears. because the fat grafts are helpful in order to help fill in the defect. And the stem cells are really often very, very useful for people who have rotator cuff tears. And again, not only does this work, but it works better than what's being done traditionally now. So again, great therapies. I've used them on myself. I used them on lots of patients, and we really have very good outcomes. And fortunately, the outcomes are better than just putting a steroid injection, which is a blanket treatment that may or may not work, but often can do damage, not only to the tendons of the rotator cuff, but often can help accelerate the arthritic process. But with what we do, we try to reverse all those processes and give long-lasting results. So when we want to choose surgery, because listen, there are times to where surgery is needed in patients. And for example, if someone has a tear in their meniscus and they get what's called a bucket handle tear, to where their knee locks up, yes, perhaps regenerative medicine may not be your first choice. It may be important to go in to have surgery. Or there are some people who have arthritis that is really, really severe that maybe regenerative medicine isn't their best choice. But I often have many patients who are told they're bone on bone, and these people often get very good results with regenerative medicine and are able to avoid joint replacements. So I think that in most cases, regenerative medicine should be the preferential treatment. But yes, if I have patients that come in that need surgery, we advise them to have surgery if we think that that's the better alternative. So here's one of my patients, Lauren Hernandez. You may know her from the U.S. gymnastics team. She won a gold medal and a silver medal. And also she was on Dancing with the Stars, and she's been in Disney movies and things like that. And Lori will talk about what I do, but she came to me when it was, I think, about a few months before the Olympic trials. And she had been sidelined for a long time with a leg injury that no one was able to help her with. And she had undergone therapy and steroid injections, all different types of traditional treatment through the U.S. Olympic team and seeing orthopedic surgeons around the area. And since I'm known in the gymnastics field of taking care of a lot of high-level gymnasts, including some world champions, Lori decided to pay me a visit. And fortunately, we were able to get her better, and she qualified for the Olympic team, and she can tell you her story. Oh.
Hey guys, this is Lori Hernandez from the 2016 Women's Gymnastics team from Rio de Janeiro, Brazil. I just wanted to talk about Dr. Greenberg and how he's been so important in my gymnastics career. I came to him when I had a strain in my VMO, which is part of my knee, and after a couple of appointments, he got me back to 100% so I could compete. So, thank you.
And things like that, and what I do with my patients every day, that just brings joy to my life, to be able to help people that are really struggling, whether they're pro or Olympic athletes or people that, whatever their age is. I've had patients from 9 years old to 99 years old that we've been able to help them with their problems. And being able to fix someone is really such a great thing in life. And, that's why I get up every morning with a smile and head into my office and work really hard, and always try to also develop new therapies, and always look at everyone's body and give every patient the time that they need, not only for me to diagnose them properly, but also for them to understand what's going on in their body and causing their problem, because I think that that's really an invaluable resource. And there's no such thing in my mind as a 2-minute office visit or a 5-minute diagnosis. It just doesn't happen like that. So, and that's what I do, is to give a person the time that they need, and the caring that they need, in addition to trying to find the solution that's going to end their problem. So can the Greenberg method help me? Often, yes, we can. I'm very fortunate that I have a lot of experience taking care of people, and thank goodness, our people become ambassadors for ourselves and for what we do. And I always joke around, with what I do, it takes time. I do have to put a bunch of needles in people. It is what it is. But if it didn't work, I think, then I would have been taken out to the town square, and the results of that wouldn't have been very good. But in fact, doing the way that I look at orthopedic issues for patients, Thank God we're extremely successful, have lots and lots of satisfied patients. And these satisfied patients, are our ambassadors and send us lots and lots of people over the years to help their friends and family and loved ones who suffer as well. And, for me, again, like I said, I treat everyone like family. So my family keeps expanding and expanding and expanding. And it's really just such a wonderful thing for my life to help these patients. So again, I'm affiliated with Bryn Mawr Hospital. I'm also a clinical professor at Jefferson, and I help to teach the fellowship program at the Marcus Institute for Integrative Medicine. The fellows come to my office and learn what I do. In Jefferson, it's really a nice thing because we have a lot of academic connections. And at Bryn Mawr Hospital, you see one of my patients here on the left. And just to show you how much conviction people have in me, this is one of my patients who decided to donate several $1 million to the hospital in order to help the integrative and regenerative community. And she helped to build a center to which I am their affiliate for regenerative medicine. And, this really brings a lot of what we do to the forefront. And again, I'm really, very blessed for the support that the community has brought me. And for me, it's really important to be affiliated and recognized by one of the top-notch hospitals in the Philadelphia area at Bryn Mawr Hospital, and also with Thomas Jefferson. So if anyone has questions, I'll see how many we can answer. I really thank everyone for attending. I know it's a Sunday and we all have plans and a lot to do. We're all very busy. But again, taking, your health into consideration is one of the most important things. If anyone has any questions outside of this at any time, all of my members of my office are always available, and I'm always available to answer questions and to, again, treat the people who need us like family. So please call our office with any questions as well, or email us, and we'll do our best to answer you, to provide guidance or any type of suggestions that we can to help your life. And here's our general email address, and again, our phone number and our location. So if we can take a look at a few of the things in the chat, perhaps I can answer some of these questions. I saw something about Parkinson's. Katie, are you able to show me the different questions, or is that not possible? Or maybe you can text me. I saw something about Parkinson's. I deal primarily with regenerative orthopedic conditions, but there are some things that are helpful for Parkinson's in regards to using different substances that help the brain, such as IV NAD, and also using glutathione. There are some interesting things that can be done in order to help neuromuscular conditions. And in fact, Parkinson's patients can get better and can have some improvement. So again, it's a combination of using nutraceuticals and IV agents for patients who have Parkinson's. I saw someone asked a question about lumbar stenosis and cervical stenosis. And again, these are very routine things for me to treat. And again, the woman who I showed in the video, not only did she have issues with her lumbar spinal stenosis, but again, as I mentioned, she had cervical stenosis that was pinching the nerves in her neck that run down into her hands. And she was actually dropping objects and was losing feel. And again, she really had problems with everyday life. And fortunately, after her stem cell procedure, her feeling in her hand came back and her grasp came back in her hand, which is really neat. And, for me, I'm also lucky that I get to treat a lot of doctors. And one of the doctors who I treat, he's a surgeon, and he was having a problem dropping his instruments and couldn't operate anymore. And fortunately, we were able to produce a stem cell procedure into his cervical spine and get his nerves to start functioning again. And the really neat thing was within 3 weeks, his grasp was fully back in his hand and his strength became full to where before it just wasn't. So it's really a nice thing in order to do that. Someone's asking about how long will it take to get results after stem cell. We normally tell people it takes at least 3 to 6 months, but often we do see changes within 3 weeks in some patients. But it does take time in order for things to rebuild and to regenerate in some cases. So again, it does require patience. We are trying to look for long-term regeneration, but again, getting immediate change is something that we'd like to see, but we don't often see it. But again, we look for the long-term results in patients, which sometimes can take a few months of treatment. So it does take some patience at times and for people to hang in there. But again, we do see it often, some quick results as well, which is nice. Any other questions anyone has that we haven't answered here? Let's see if I can scroll through here. Or if you want to text me anything, Katie, that you saw on your...
Dr. Greenberg,
Yes.
have you felt long-term pain in joints for an 85-year-old?
The answer is yes. We have had plenty of patients who are 85 years old that we've dealt with long-term joint pain with them, and even in some patients that have had joint replacements or have had surgery. So the answer is yes. So.
Great, thank you.
What's that?
Thank you.
Yeah, so believe it or not, so a lot of people think, oh, well, I'm older and are my stem cells going to work? And that's a really good question. And what's been shown in research is actually that while your stem cell numbers may go down somewhat, the quality of the stem cells is something that doesn't change in life. And if you have stem cells in your body, the quality of them is going to be as good as a younger person. So, so treating older individuals isn't necessarily a contraindication for regenerative medicine. Someone asked a question about sacroiliac joint pain. And again, this is a very common thing that we see. I treat it almost every single day. We see people with SI joint problems. And again, you can't just treat the SI joint. You have to rebalance the pelvis and fix the musculature that connects to the sacroiliac joint as well. And that's how you get a really comprehensive treatment. And that's how we provide relief to our patients. So someone asked the question, are stem cell procedures covered by insurance? And unfortunately, the answer is no. So, for people, we have to look at it two ways. Number one, we have to be able to invest in ourselves and invest in our health. In addition to that, we also need to think about the cost of chronic pain. And suffering in chronic pain can cost someone thousands and thousands of dollars in their lifetime, both by undergoing physical therapy or medications or testing or hospitalization, or even a loss in work productivity that really makes a very significant impact on their life. Now, someone else asked, why is it not covered? And I'm going to give you a few different reasons. Number one, some of the answers are political. And as I mentioned, I was lucky enough to treat the spine of Dr. Coop, our former Surgeon General. And I asked Dr. Coop, I said, listen, you know how well this works. And I said, what's going on and why can't we get this approved by insurance? So Dr. Coop went before the Board of Medicare, which he sat on the board. He talked about all the research behind everything that we do. And they took a vote. And Dr. Coop also gave his personal testimony, how it was really the only thing that helped him with his back. And when it came time to vote, unfortunately, he was the only person on the Board of Medicare who voted yes. And everyone else voted no. So Dr. Coop, being an inquisitive guy, said, hey, how come no one's listening to me? I'm telling you how great this is, and it needs to be covered by Medicare, which if it was covered by Medicare, then it would get covered by every insurance. And they told Dr. Coop, who told me directly, so this is not a whisper down the lane, that if they did do and cover something like this, it would take so much of the medical care and make it obsolete, which would basically ruin the economics of the medical system. So it really is a shame that it's like this. But interestingly enough, I have patients who have some private health insurance that are now getting coverage. I also have a number of patients who belong to Christian health sharing groups, and these health sharing groups have really been very forward thinking and have covered a lot of my patients' procedures because they know what we do is extremely effective, and also it costs far, far less than spinal surgery. So the fact of the matter is that it is a very cost-effective thing, and in due time, perhaps there'll be more insurance coverage. Be that as it may, as I may have mentioned, I'm also a consultant for a major biochemical firm called DSM Biomedical, whose American division is based in Exton. I just had meetings there this Friday, and if we're successful, which is one of the projects we have, is to try to fund research in order to show how effective the treatments that we do are, and eventually, if we can publish enough studies on this, then we may be able to get insurance coverage. But listen, this is down the road. It'll take years in order to accomplish these goals. But this is one of my long-term goals of working with DSM Biomedical, and I'm hoping that we can get coverage down the road. But unfortunately, we can't right now. So. But anyhow, I want to thank everyone for attending. And if you have any questions, please feel free to call our office. We're always looking to help as many people as possible in any way, shape, or form, or at least provide some guidance if need be. And we hope you enjoy the rest of your day. And everyone take care.